Welcome to everyone, and thanks so much for joining us. My name is Danielle Lauder, and I'm the director of the Northeast Telehealth Resource Center, and I will be the moderator for this session here today. I just want to provide a quick sort of tip. If you have questions, please enter those questions in the app, the Event Mobi app, via that question option, and we will be tracking those throughout the session, and we'll have a 10-minute, 15-minute Q&A session at the end. We'll also have an opportunity to kind of open things up. We'll allow folks to unmute and speak and ask questions out loud as well. So please know that we have that planned at the very end. Another reminder that you can upvote questions. So if there's a question that you're really interested in hearing the answers to, you can just click on the little arrow next to it, and that upvotes it, brings it up to the top. So that we can make sure that we kind of prioritize and get all the questions answered as folks are interested in. And then to reiterate from this morning, we want to keep the bios really short. So I'm going to introduce our wonderful speaker here today, but I'm going to keep it very, very short because we want to give him all the time to share his expertise and lessons learned. So unfortunately, Carrie Dostie is not feeling well today, and so she's not going to be able to join us. However, we do have Dr. Wasim Ghanem, who has graciously agreed to do the presentation via solo. Dr. Ghanem is CEO and co-founder of Telehealth Solution, and he's going to be sharing today about telemedicine in the age of the pandemic, specifically around post-acute care and bridging care directly to patients. And we are so excited to hear what he has to share with us here today. And without further ado, I'm going to go ahead and turn it over to you, Dr. Ghanem, and thanks so much for being with us.
Thank you very much, and thank you everybody for your time today. I'm Dr. Ghanem. It's good to meet. Good for this opportunity. I'll be filling in as well for Carrie Dostie. She's unfortunate, as Laura mentioned, not feeling well, but I think given the amount of relationships I've had with AMD, I can kind of fill in for both sides of the fence. So with that being said, I'm Dr. Ghanem, co-founder, CEO of Telehealth Solution, and my little 30-second pitch is we've been doing telemedicine now for over 5 years. So we've been doing telemedicine before it was, recognized, or before it was quote unquote cool, if you will. So we'll kind of go into the next slide here. A little bit about who we are and a little bit about AMD. Telehealth Solution is the way that I always position our company is we're a provider group composed of now, over 80 providers who just specialize in telemedicine services. And that's important because I think our end in this healthcare spectrum is having that provider group that understands, knows, and how to leverage telemedicine services. I think a lot of times where we'll find our biggest clientele or our biggest areas of opportunity is the clientele or the nursing home market wants to leverage telemedicine, and they may have a medical director or may have a med staff that isn't going to be as engaging or as involved, if you will, in leveraging that telemedicine opportunity. Certainly for AMD Global, they are they are our digital medicine partners. They've been in the telemedicine field now for nearly 27 years. They provide hardware, software, complete soups to nuts, if you will, of a telemedicine platform. I believe AMD is now in over 112 countries. They've done over 10,000 touch points. And so I consider them a respected industry leader when it comes to the hardware, software side of telemedicine services. So with that being said, we'll go to the next slide. So COVID-19 and telemedicine, I think, again, COVID-19 really, telemedicine has existed prior to, telemedicine has existed prior to COVID-19, but I think, what COVID-19 did is it brought into an era or a landscape of really transforming how medicine was being applied. And I'll give you all an example of nearly every nursing home in the country was under lockdown for the past 3 months. Most of them still are in lockdown. I believe in certain markets like in the Northeast are starting to open up nursing homes. And so, when you think about it, is basically telemedicine got thrusted into the spotlight, if you will, just due to the pandemic. And so there's been a huge emphasis on telemedicine due to COVID. And I think, you know, this part of the industry has been able to answer that challenge. And one thing that I will tell people is, I get a lot of opportunities where people are like, oh, I like to do telemedicine. Telemedicine to me is just a broad term. It's really, what do you want to do within telemedicine? Meaning, from my areas, I've been able to experience telestroke, meaning having patients doing teleneurology and evaluating patients in rural hospitals. There's telepsychiatry. So telemedicine is not a new field. All it is it's a bridge, if you will, of service lines that allow for patients to connect with providers. So it really removes that geographical constraint. So we can go to the next slide. Where does telehealth solution deliver in regards to COVID-19 management protocols and success of patients? I'll give you all an example. A lot of nursing homes have developed and designed a COVID-19 unit. And that's where they'll put patients in quarantine who have had fevers, temperature spikes, increased respiratory rate, signs or symptoms suggestive of COVID-19, or have been exposed to a potential patient who had COVID-19. A lot of nursing home clients have also basically created a quarantine unit where a patient who's coming in from a hospital will stay for a period of time before joining, the rest of the residents. So the power of telemedicine in these COVID-19 units has been, why should a skilled nursing facility expose their providers to physically rounding on these units if we're trying to minimize or mitigate any potential risk infection or risk infection protocol? And so telemedicine has offered that ability to round on a patient daily, set and establish a protocol with that organization, and that protocol can be replicated across their portfolio. But then it allows you to round on those patients daily, minimize any potential risk or exposure of infection, really be able to update the family. When giving you all an experience from my end, when I was seeing patients on COVID units, a lot of times you're looking at all the subtle things. Do you see any jugular venous distension? Can they give you a full sentence? Do they appear to be perspiring? And so those are the slight things that, even though as a physician, I will tell you, nothing ever beats putting hands on a patient. But at the same token, you have to be very prudent in that thought process, meaning, am I causing potentially more harm than good by being in these rooms and possibly spreading it around? And so that's really the beauty of telemedicine, is being there for that patient and really doing it in a scalable fashion, meaning, you're touching a home in rural Mississippi, and then you're going to see some patients in northern Wisconsin, then you're going to jump over to Ohio. And so as a provider, it's a very satisfying or gratifying feeling to know that you are able to deliver that change and that result across the country. So that's kind of these telemedicine rounds. And when you're setting up protocols with clients together, it allows for that ability to say, are we delivering the same amount of care in Clinton, Maryland that we're going to be delivering in Shelbyville, Kentucky? And that is really fascinating for me, when you're able to standardize and scale protocols, especially in an era of a pandemic. Also, during this COVID era, employee screening. You've had CNAs, LPNs, DONs, executive directors. They have not been immune to this. I've really been on the other end where it's been a challenge watching, nursing home personnel succumb to this pandemic. It's been a concern. I mean, these folks, obviously, they too need access to care. So again, from telemedicine, this pandemic, if you will, created almost an employee health portal, where you've got an LPN who's doing a double shift and isn't feeling well, now has that ability to also access a doctor. And so that's powerful. From a family perspective, this has been a real challenge for me as a provider and as a physician. Is I couldn't imagine. I've had to talk to families about patients who are not doing well, had to bring them in through the web portal so they could see their loved one. It's a challenge when a family member or son or a daughter know that their mother is not doing well and that the building is under lockdown. So telemedicine, of course, it never replaces the ability to hold your mom's hand or hold your dad's hand. But what it does do is it lets that son or daughter or family member or healthcare power of attorney to get a some optics into the situation versus just getting a report from the physician or from the nurse taking care of them. So they're able to see kind of what's going on with dad. And that, in the challenging cases, of course, that's sad when you're going through those moments. But then there's also the win when, a patient's rebounding from COVID-19 and, the son or daughter is at least able to video in and kind of give that family member some encouragement. Because one of the things that you'll see in geriatrics, especially those, is the geriatric patients can quickly become withdrawn. They won't eat well. Their mood starts to dampen. And so having that ability for family to kind of portal in and say hello to mom or dad really livens up the spirit. Again, augmented medical director PCP care. We had many scenarios across the country where the medical directors just weren't able to get into the building. And now you have a medical directorship group that may or may not have been exposed to telemedicine. And so they're trying to scramble and trying to, get access to their patients. And so this provided an opportunity to work hand in hand with the medical director and kind of bridge any potential gaps from a building. We can go to the next slide. So I'll give you all a scenario. This is just a classic scenario of what goes on in telemedicine. This was prior to the COVID pandemic, if you will. So you have a patient, her name is Mrs. Smith. She just recently was discharged from the hospital. She unfortunately suffered from a stroke. She comes to the nursing facility with a PEG tube. She just got there about 48 to 72 hours ago. It's now Saturday at 3 a.m. She's coughing. She has a fever. She's not doing well. She's tachypnic. Her respiratory rate is in the high 20s. Her pulse ox or oxygen saturation is in the low 80s. In almost every scenario, when I go around the country and I ask these homes that we work with, if you put a call out like that, what would your answer be? And your answer would almost unanimously be, we'll just send that patient off to the ER to get evaluated. And I know that sentence right there seems, reasonable. But then you think to yourself, look at all the sequelae of events that are about to occur because of that sentence, meaning we're about to activate EMS. We're about to take a patient with cognitive impairment to an emergency room department. We're about to have an ER physician, an ER nurse. That patient's about to be basically gowned up with a thin sheet. There's going to be a laboratory bill. This patient's going to have a chest x-ray. This patient will more than likely be admitted. The nursing home is going to get dinged for this readmission. This patient's going to spend about 2 to 3 days in the hospital as a readmission. And given her cognitive impairment, she is going to become hospital-based delirium and end up doing worse than better. And at the end of the day, this patient was just treated and I think for all of our friends on here, you probably know that she likely aspirated, what's known as chemical pneumonitis or aspiration pneumonia. We can go to the next slide. So kind of a telemedicine treat in place model would have been, with those same symptoms being identified, a nurse puts a page out. That page is responded to. On the conversation with the nurse, it is deemed that this patient is sick and needs to be evaluated. A nurse brings in a telemedicine cart into the room. That telemedicine provider evaluates that patient remotely. And we can go to the next slide with the evaluation. We can go to the next slide. Yep. So that patient is now being evaluated remotely. And, that provider, if you will, has identified that this patient is aspirated and will say, let's turn the tube feeds off. Let's give Tylenol. Let's do some normal saline fluids while the patient's NPO through PEG tube feeds. Let's have nutrition see the patient tomorrow. Let's get a CBC, basic metabolic panel. Let's get a chest x-ray. Let's look at the allergy list. They're not allergic to anything. Let's go ahead and give the patient albuterol. Let's go ahead and do a suction, see if this patient's aspirated and anything that we need to pull out via suction. Let's do some of these things first. Let's also call the family member under the profile section of their EHR. Let's call the family member and involve the family member. All too often, patients are sent to the hospital or things are being done and family has little to no involvement in this patient's case. So let's call the family member and say, good evening, this is Dr. Ganem. I'm calling on behalf of your dad over at XYZ organization. And I just took a look at him and I think dad's probably aspirated. Let's get the family involved with a treatment plan and let's try to treat that patient first. I'm not saying let's not go to the hospital, but let's do the same things that we would have done in the hospital first at the skilled nursing facility. If this patient's not improving, then we can always send that patient to the hospital for further evaluation. And so under that kind of a model, your patient with cognitive impairment, she's now getting the labs drawn at her room in her facility. She's now getting that chest x-ray administered in her room via a mobile radiology company. She's getting the antibiotics in her room. She's getting these treatment plans in her room. She's less likely to suffer from delirium because she is not in an unfamiliar surrounding. And quite honestly, it's just better care for the resident. I mean, as an individual, I don't think I would like being woken up at 4 a.m. and sent to an ER to sit for hours. So imagine what that does to an elderly patient with cognitive impairment. I think I go on this, I remember my days in residency and in training. One of my residency instructors, she would take all of the residents and tie all of our feet and tie our hands and would put glasses on us and then cover the glasses with toothpaste and tell us to get up and walk and do things, and said, welcome to the world of geriatrics where vision is lost, mobility is impaired. And so, you know, it's challenging to do that to people. And so, you know, try to do some things first if you can to treat that patient in the building before you send them out to the emergency room department. We can go to the next slide. There's certainly an ROI with regards to telemedicine. I know right now in the era of COVID, everybody's census is low overall, but prior to COVID, if you had a 100% bed occupancy rate, and you know, one of the discussions that we have when we go to different nursing homes is they say, well, I'm doing a great job getting all these patients in and my occupancy rate's 92%. And I'm like, that's fantastic. But you also have a 35% return to hospital rate. So it's like a bucket with a hole on the bottom. You're getting patients in, but then you have to perpetually keep trying to get new patients in because some 32% of the patients that you do get in are going right back to the hospital. And of course, this also causes, you know, when you have a high readmission rate, you now fall out of favor in a hospital's narrow network system because hospitals are all looking to partner with skilled operators who have a, you know, lower unplanned hospitalization rate and pretty much build them up in their narrow network. And if you're a part of a hospital's narrow network, well, what does that mean now for your post-acute care organization? Meaning you're more likely to get, you know, more of a tier 1 kind of a patient than getting a patient that's very difficult to be placed. And of course, there's always the ROI of lost opportunity, meaning you're holding a patient's room while they're sitting in the hospital for 2 or 3 days for things that you could have treated. And certainly with the PDPM era, you know, you're not being able to capture some of the severity of what you can treat, given that you sent the patient out to the hospital. We can go to the next slide. So some important things to stop readmissions, you know, from my optics, telehospitalists and ER physicians, again, if you're trying to build a telemedicine program where the goal is to curb return to hospitalizations, well, you need to have the proper physician composition group. I once met with a client in Florida and he was upset that he wasn't getting any reduction in his return to hospitalization. So I said, can you give me an opportunity here to look at what's going on with your program? Well, I quickly realized, looking at the physician composition, the telemedicine group that he was using was giving him retired OBGYN, retired dermatologists, and retired radiation oncologists. While, mind you, these are all physicians, these aren't physicians who are trained or have the qualification to deal with the certain complexities of what's being asked of from the organization. So, you know, one of the first things that as a consumer you need to look at when implementing a telemedicine program is, if you're trying to address a certain goal, you need to make sure that you're getting the providers who are qualified and capable to address that goal, not just being sold on the, we have nice gadgetry, we have nice technology. EMR integration is very imperative. EMR integration allows for driven data and driven documentation. So when you have an EMR integration, you're going to avoid redundancies, meaning when you get paged out, I expect to have the most recent labs, the most recent vitals, the most recent, code status, the most recent allergy list. EMR integration is imperative. Notification system and reporting tools. You may have the best telemedicine program in the country, but if you do not notify the PCP in the morning of your overnight events, or you do not have a mechanism to notify that PCP, then you're only as good as your last consult. And how is that PCP going to know what you did overnight? Put yourself in that PCP's shoes. That PCP shows up on a Tuesday at 9 o'clock in the morning and wasn't notified of any overnight events, and he or she is now rounding in the building, and isn't aware, if you will, of any of the overnight events. Well, they just came in and out of that building and didn't even see any of the acuity that you were managing. That leads to fragmented care. Nursing staff satisfaction, again, that's very important, is when you're building a telemedicine program. In the post-acute care industry, callback times are very jaded. Callback times can be delayed. And so you want to drive it from a consumer end to make sure that you have a engaged nursing staff, because if you don't have an engaged nursing staff, or you don't have a platform that's easy to use, and I've seen this firsthand, then what you're going to have is a telemedicine cart sitting in a closet somewhere. Again, improved communication. That's obviously the goal of almost every program. Peace of mind for residents and families. Again, as I mentioned earlier on the vignette, you got to involve families in the conversation. I always kind of harp to my med staff. The best person to talk to is a family. Family will tell you everything that you want to know about a patient. Sometimes they'll tell you too much. But speaking to a family will give you the sense of missing points of data that you otherwise may have not had. I'll give an example. I was seeing a patient in Shelbyville, Kentucky. He was slurring his speech. He had a little bit of facial asymmetry. Of course, the concern is for a possible stroke. Before I sent him out to the hospital, I called his daughter and she said, "Please, doc, don't send my dad out. He's had about 20 of these. Every time we image him, nothing shows up. I'm aware of it. The family's aware of it. He can't enunciate his wishes. He is a DNR, DNI. Do not hospitalize." And so this gentleman would have gone to the hospital for a full stroke workup yet again, had we not spoken to family. Emergency room follow-up. This is very important. When you send a patient to the emergency room department, when I was practicing hospital medicine and critical care, when you send a patient to the emergency room department and the only note that comes with a patient says fever or white blood cell count, put yourself in the emergency room department's physician's shoes. It's very tough to send a patient back to a nursing home if I don't have an engaged provider on the other end, because I have to think to myself as an ER provider, who's going to follow up on this patient? Who's going to follow up on the labs? When will they even be seen? And if I don't have any of those concerns addressed, then the easiest thing for me to do as an ER provider is just to admit the patient upstairs for my medical legal liability. So that's a much different conversation than if you sent a patient to the ER who fell, who hit their head, who's on a blood thinner, and you say, "Good evening, I'm Dr. Ganem, calling on behalf of XYZ Nursing Home. Can I speak to the ER doctor taking care of Mr. Smith?" You got the ER doctor on the line. "Hey, this is Ganem. I just sent over this patient. They fell, they hit their head, they're on Xarelto. I was hoping you can get a CT scan of this patient's head. If it's negative, we'll be more than happy to send the patient back." The emergency room department doesn't mind to send the patient back. They just needed to know who's going to carry the baton of liability. And so this positive communication or closed loop communication allows that to happen. We can go to the next slide. Marketing telemedicine services for SNF growth. I think we can all agree that the era of telemedicine is here to stay. People always ask me, what are your thoughts on telemedicine? What are your thoughts on telemedicine billing? What are your thoughts overall? And I use the toothpaste and the tube analogy. The toothpaste is out of the tube right now when it comes to telemedicine, and good luck trying to put it back. Because, when almost every doctor's office in the country was closed as far as a primary care, and, nursing homes were closed off to outside visitors, one of the few sectors of medicine that was actually thriving and doing well and answering the call to all of this was telemedicine. And so I think from a marketing and telemedicine services for SNF growth, If I'm a hospital administrator, the first thing I'm going to ask now, if I'm going to send patients to a SNF, is I'm going to say, do you have a digital medicine strategy? So what I think personally is what the COVID era has done is pretty much awoken every post-acute care industry organization across the country that when we get past this pandemic, do we have a digital medicine strategy moving forward? Because I don't think it's going to be acceptable to not have a digital medicine footprint or strategy. And I think if anything now with the era of telemedicine is if you don't have a digital medicine strategy and your neighbor does, they're going to use that to their advantage. We can go to the next slide. So this is just some of the AMD. I'm going to now pretend to be Carrie for you all. So some of the things that AMD does is they do obviously remote doctor consults. The way that you do a remote doctor consult is you have a platform. That platform lives within your building. It's a cart that has over 40 different attachments, and it allows for remote doctor consults, and nothing is stored on there. It's all HIPAA compliant. So it's a store and forward, meaning after you've seen that patient and aggregated your data, it's now forwarded into the EHR of your choice. It's HL7 integrated. And so when you're done with your encounter and you close your encounter, there's nothing else stored on that encounter. They certainly also have a direct-to-consumer platform known as Connect and Care, which is a mobile version of their work. They've certainly integrated as well remote patient monitoring into their portfolio with a multitude of platforms. I think we've seen as an industry a huge surge in remote patient monitoring now, especially in the home health sector, where patients are now going home with a monitor. In the past, it used to be like a Holter monitor, which now communicates with a Bluetooth gateway hub and sends off any particular alerts. I'll be the first to give you all an example. Patients just recently discharged from the hospital from a cardiac rehab program. Patient goes home, has a patch. That patch connects to a Bluetooth gateway hub. If there's any cardiac arrhythmias, that hub now notifies us via SMS to log in and view that patient's tracings, and then we're able to connect to that patient remotely and have that conversation with them if anything is going on. We can go to the next slide. Some of the biggest drivers for telemedicine adaptation: patient satisfaction. And this is me speaking on behalf of AMD. Do patients like telehealth? Quite honestly, a lot of times from my end, people would say, I don't think patients or seniors are going to like telemedicine. And the item is I'm not so sure that I agree with that statement. Seniors are very adept to using FaceTime and WhatsApp to get in touch with children and grandchildren. So I think as an era, we've started to embrace, if you will, telemedicine. I can tell you certainly from my aspect, where we do telemedicine, it's not a replacement of that hands-on provider. It's an augmentation, meaning it's those opportunities where there isn't a provider in-house. Clinical efficiencies. Can we provide quality care via telemedicine? The answer is absolutely yes. We have clients, for instance, in Eastern Kentucky. During this COVID pandemic, access to an infectious disease doctor was limited. Given our clinical network platform, we brought access to infectious disease specialties to some of our clients across the country. So that is a quality care and clinical efficiency. Obviously, business value and ROI. Again, I'll give an example. You work at a rural hospital. This rural hospital only does 1 or 2 admissions the entire night. That rural hospital is having to pay Dr. Ganneman flesh to be there, where the majority of my night is sitting in the doctor's lounge watching television in case an admission comes. That is a very costly proposition for that hospital. And when you look up the amount of closure rates in rural hospitals, they're closing at a much more alarming rate than their urban counterparts. And so the business value proposition is these hospitals still have access to telehospitalists or tele-ICU, but are doing so and leveraging that through telemedicine, where they have access to these professionals, but at a much lower cost than having these professionals in-house and in flesh. Next slide. Patient satisfaction, again, kind of continuing on here. Patients show a rate of about 90% when using a telemedicine platform. Patients are satisfied because they feel, especially if you're doing on a direct-to-consumer or you're doing this in a patient's home, again, On a direct-to-consumer model, I have a cold, I have sniffles, I have a sore throat. I would have had to drive myself in a car, go to the PCP's office, sit and wait, or I would have had to go to the urgent care, pay a copay, and sit and wait. Now I'm getting my question addressed immediately at my own luxury or at my own times. Clinician satisfaction is also high as far as with telemedicine. I'll be the first to tell you, as a provider, I experienced burnout. I did not like sitting in a hospital 12 hours a day. Now I'm still able to leverage being a physician, but doing it on my own terms from my own location of my choosing, but still being able to effectuate change across the country with the different various entities that we work with. There's still statistics here about clinicians being virtual visits were better than offices from a timely scheduling of patient appointments. Absolutely. Again, you look at your efficiency standards. When you have an office, you look at all the costs of your brick and mortar versus having a virtual office for your clients. We can go to the next slide. Comparison studies again. Chronic care conditions, especially in the rural settings, significantly improved care. I'll give an example to that. We, as an organization, have extensive work in the state of Oklahoma. Being able to deliver a telecardiologist in the panhandles or in the rural parts of Oklahoma to follow patients from a CHF perspective, these patients would have had to drive 200 to 300 miles to get to a cardiologist. That is significantly effectuating the change in landscape of care. No difference in the ability for the provider to obtain clinical information. Again, being able to have EHR access integrated into the EHR, it's as if you were in my office. We can go to the next slide. Here, I'll kind of leave these as far as for how to determine your business value. You can certainly take a look at, what are your business drivers. I think the first thing as an organization you have to look at is if you're looking into a telemedicine program, you have to ask yourself, what is the question or what am I trying to get addressed? And so based off of that is then how you start building your business value proposition. We'll go to the next slide. Success, again, happy patients, happy retention rates, patient engagement. These are all, of course, intangibles. Next slide. When choosing a service line, again, it's again that saying this kind of harpens on my own discussion that I brought to you earlier. Making sure that you have that physician composition group that you are expecting, making sure that they integrate and work well with your existing medical staff. The last thing that you want is your medical director feeling that this service line that you're bringing in is confrontational to their work. Okay, we'll go to the next slide. Service providers, again, making sure that these providers are licensed in the states that they work. I want to leave a little bit of time for Q&A, so I'll go through to the next slide. Some data outcomes. We'll get right into it, please. And I'm guessing that slide for our data outcomes.
Dr. Ghanem, I have the updated slide deck, and I will go ahead and share that right now. I just got it via email, so.
Okay. Yeah, our data outcomes was pretty, from our end, I was pretty excited about it.
Excellent. So just wanting to confirm that you can see that, okay?
Yep. So from January through May, Telehealth Solution, this is our data. We had about 32,610 encounters. When we treated patients in place, 39% of those encounters, we treated the patient in place. This is a composition of all of our calls. When we sent the patient back to the hospital, we sent back, of all of our patient encounters, we sent back about 3.55 patients went back to the hospital. 1.12% of those patients as well, we were sending them over and bringing that patient back, meaning if the CT scan is negative, can we bring the patient back? I know that number may seem like, well, you only brought back 25%. Correct. But we also mitigated and lowered how many patients we even sent to the emergency room department, meaning you're really only sending patients to the hospital that need a higher level of care than what can be provided. And so that's where it's very important to kind of understand how that data is looking like. So with that being said, I wanted to share that data. Now I'll take a pause or go into any kind of questions,
Great. So we do actually have one question, and just a reminder to everybody to please post additional questions that you may have in the actual Event Mobi app, and be sure to upvote if there's something that you would really like to hear Dr. Ghanem talk about and answer those questions. So the first question we have you heard that patients with COVID, acute respiratory distress, can progress fast to need intensive ventilator support? Do most of your service SNFs try to get by with non-invasive ventilators, or is breathing support needed get to the turning point to ED visit?
Okay, I'm trying to view the question here. One more time, if you could tell me the question, I'm sorry.
Sure. So, and Jason, if you could share too the questions, I think that's possible for you to do so that we can see them. But have you heard that patients with COVID with acute respiratory distress can progress fast to needing intensive ventilator support? And do most of your service SNFs try to get by with non-invasive ventilators, or is breathing support needed?
Right, and so that's a good question. Most of our cases, we've been able to get by without ventilator support. I think the mitigating or risk factor in the patient who might need a vent is really the instance here, guys, is patients who had already a structural lung disease, such as chronic obstructive pulmonary disease, such as cystic fibrosis. People who've already had a structural lung disease, those are that high-risk patient panel who can potentially decompensate quicker because they already did not have enough, if you will, reserve or tidal reserve, that should they have succumbed to a COVID-19, they just would not be able to fight it than a healthy senior otherwise stated. And so that's the more high-risk patient panel that we had seen who would, in essence, decompensate much faster than your traditional patient.
Great, thank you. So we have another question. Old reimbursement policy barrier was due to very limited numbers of telehealth visits per week. What data is needed to support now reverting to this policy after the public health emergency? That's a loaded question.
Yeah, that is a loaded question. So here's how it was. We used to have telemedicine, and it was only available in the rural and what we called a designated site. So there was always reimbursement and CPT codes available for telemedicine, but it was only for your rural and remote areas. And I think right now, and I think today, actually, my colleagues in this digital reimbursement or facility will now drop. So I think what we're still on point, but I think right now we're at that era that it's going to be very challenging to say, no, we should just go back to rural and remote areas that only get the benefit of telemedicine.
Okay, so Dr. Ghanem, I apologize, but we missed a good chunk of that answer because I think there was a connectivity issue. I don't know if you want to repeat just a bit of it.
Yeah, of course. This is a very important question.
Thank you.
So telemedicine, there's always been this billing opportunity, but in only rural and originating sites. You would have to go on the Medicare eligibility analyzer site to see if that facility would be eligible. I hope I didn't break out. What we're going to see as an industry is, I think telemedicine is in essence here to stay from a billing perspective. The only thing that from my optics that will kind of insight, right now we're not practicing, a lot of organizations aren't practicing in a HIPAA compliant fashion. They're using FaceTime or WhatsApp. I do think that we will see a scale down of that.
Absolutely, and I think we're certainly hearing very similar things within many different venues that we're traveling and as telehealth resource centers, and it's going to be interesting. But we certainly hope that they don't reverse a lot of the important policy expansions that have been put in place under the public health emergency. Can you hear me?
I'm
okay?
Sorry, got in and out. Can you now hear me? Apologies. My Zoom meeting keeps logging me in and out.
Okay, so we could have you join via phone if we keep continuing to have the issue, but I do have a couple of other questions, and we can.
Yeah, sure.
Okay, great. So from Scott, considering how long the technology has been available, one could argue that adoption of telemedicine was a reactive measure, certainly. Do you think that telemedicine will continue to be reactive, or do you think that our society has learned its lesson? Do you think a lot of the rules that were opened up due to COVID will remain in place? So a little bit of a recap on that policy.
Yeah, I think first of all, and I will tell you, it really takes both sides of the fence, meaning, when telemedicine was we've had telemedicine for years. It was always in the teleradiology world. You know, people think, oh, telemedicine just started a year ago or 2 years ago. No, absolutely not. It's what was happened, though, when you look at the timeline of telemedicine, you had state governing bodies, for instance, in the mid-2000s say, no way can we provide telemedicine through an app on a phone to a different. So as a society and as an industry of medicine, I think both sides have now become to adapt, if you will, to both the efficiencies and the qualities that are being provided through telemedicine. It's impossible to say it is not a quality driver to a rural nursing home in Alabama to bring in, you know, a cardiologist to that particular nursing home. There's no disagreement to that. From a value proposition, the same argument can be made from a value proposition or ROI, meaning look at how cumbersome it is to take a patient out of their room just to go see a pulmonologist for a follow-up, which could have been addressed and done through telemedicine. And so I think, if you will, as a market, it took this pandemic for all of us to open our eyes in a new way of thinking that telemedicine is really just an extension of medicine. And that's kind of my viewpoint on this.
Great, thank you. So we do have another question. In a project in Maine long ago, the greatest specialist needs were for psych, derm, and wound care. Does your group address these needs? And how to get specialists willing to do services is a barrier.
Right, it was a barrier, and the barrier was always in the past, who's going to pay for all of this, right? And so now with CMS saying we're going to pay for these codes, we can now do teledental, telerenal, teleoptho, telewound services. You know, it was always this, you would always go to these nursing homes or go to these organizations, and it was always a value proposition discussion, which is still there. But the old adage question was, you'd sit across from an administrator and says, this is wonderful, but I can't afford it. And so now, if the reimbursement has now aligned with this, then I think you're going to see a strong resurgence or a strong adaptation in the specialty fields. Because again, think of yourself as a dentist, and now you're able to see some of these homes in rural Maine using a dental camera through a telemedicine platform. It allows you to really start driving change on these residents who may have had fractionated dental coverage, you know.
Great, thank you. So I think we've actually, in looking at the app here and looking at the chat, I think we might have gotten to all of the questions so far. If anyone would like to raise their hand, or you can let us know if you'd like to unmute via the chat, we can certainly open up to those live types of questions for Dr. Ghanem. Okay. Jason, I'm not sure if you want to, I think we could go back to that original slide deck that you were on, and we can sort of round out the, thank you. Excellent. So anyone else with questions before we kind of wrap things up here? Thank you so very much, Dr. Ghanem. This was very informative, and just all of the different recommendations and just considerations, particularly we know that skilled nursing and long-term care facilities, et cetera, has been a very important environment to be utilizing telehealth and telemedicine, and much appreciated with you sharing your expertise and your experiences to date, and been wonderful.
Thank you so much, guys, for having me, and it's an exciting time, I think, for myself, for those in the industry such as yourself, and you know, it's an interesting time also for your panelists who are, or for your audience as they go through kind of what they're looking for in a digital medicine platform.
Absolutely. Jason, if you'd like to go to the next slide. Have to get in our reminder, right? So we so appreciate everyone for joining us here today, for joining us hopefully for the other 3 series sessions that we have throughout the virtual conference series. And this is our first virtual conference series. So as mentioned, we really would appreciate your feedback. We've tried to keep this evaluation as short and sweet as possible, but we really would appreciate you telling us how you think the session went overall, how it might be utilized in your day-to-day work. If you have any ideas for us on how to continue to improve on our virtual sessions, we would certainly love to hear from you. And again, we know everybody's very, very busy, and we greatly appreciate you spending your time with us here today and in future Fridays. And it would encourage you, if you have questions about telehealth, or if you're looking for research, peer-reviewed literature or anything like that, please reach out to the NETRC or the Mid-Atlantic Telehealth Resource Center or your regional telehealth resource center if you're from another region across the country. But we so appreciate you being with us here today. And again, Dr. Gannon, we so appreciate your time and expertise sharing it with us here today, because we know you're exceptionally busy as well. So thank you to everyone here today, and we hope you have an excellent weekend. Enjoy the weather, and we will see you again soon.
Thanks, guys. Be well.